Hi, my name's David Berg, and I'm here today with my friend and colleague, Dr. Michael Goldfarb, to discuss his recent publication on family engagement in the cardiac intensive care unit, which was just published in CIRC Outcomes. Dr. Goldfarb is a critical care cardiologist at Jewish General Hospital and McGill University Medical Center, and is an assistant professor of medicine at McGill University. Michael, it's a pleasure to be chatting with you today.
Well, thank you very much for this opportunity to discuss this important, but I think very often overlooked topic. So I
completely agree that this is an area that is sort of less familiar, I think, to many cardiologists, critical care cardiologists, clinicians in general. And so maybe before we take a deep dive into your analysis, maybe you could start by telling us a little bit about what family engagement means, and particularly in the critical care setting.
Family engagement has a number of definitions, but it really means ultimately including the family member in the care partnership. Because the family member really is an extension of the patient. And what that means in the critical care setting is that family members can be really involved in many different aspects of patient care, either passively or actively engaged in care. This could mean being physically present and providing emotional support for the patient. It could be involved being either a substitute or surrogate decision maker for an incapacitated patient, or helping a patient make decisions. Or it could even mean providing direct care, such as feeding, assisting with mobility, or preventing delirium at the bedside. And importantly, there really is increasing evidence that when you engage family in care, there's better outcomes for family members, but not only for family members, but also for patients themselves, for the healthcare workers who take care of them, and as well as resource improvement for the healthcare system. And a lot of this has been described in the critical care context, but there hasn't been much work until recently in the cardiac ICU context. In fact, I recently chaired the American Heart Association's scientific statement on family engagement in adult cardiovascular care. And one of the areas that we identified as being important is really to need to further explore the role of the family member in the cardiac ICU context.
Well, that's perfect context then for your study, and so maybe you could sort of walk us through your study design.
Yeah, so we took a survey that was actually designed by the World Federation of Societies of Intensive and Critical Care Medicine, and we distributed it to members of the Cardiac Critical Care Trials Network. So just a short word about the study itself. It was designed with nine items that assess specific family engagement practices or policies, and it had one general item about other types of family-centered care practices that happen in a critical care setting, and a couple of open-ended questions where we ask about kind of facilitators and barriers to family engagement in the cardiac ICU. And the survey was originally developed and given to a large international group of ICUs in many different countries, I think over 300 ICUs. But what was interesting was in the initial study, there was very few cardiac ICUs that were included in that. So I said, we need to know what's going in the cardiac ICUs in terms of family engagement practices and policies. So let's distribute to members of the Cardiac Critical Care Trials Network.
That's great, and I think C3TN is sort of the perfect place to sort of implement this, because there's a sort of a broad swath of different types of cardiac intensive care units that are represented in C3TN, and it's really a global network of largely advanced CICUs, but with different practice environments, some heavily academic, some more community based, and so sort of a nice cross section to answer that question. Or to sort of explore those questions. And so maybe you could talk us through what were the primary results of your survey of the C3TN with respect to family engagement practices.
Yeah, and just to further that point is we really need to know what we're doing right now in order to know how to improve the practices and policies. So the first step was really to see what we're doing. And so we surveyed all sites that were in the network at that time. And as you know, the network is ever growing. There's 39 sites and all of them 100% completed the survey. The people that completed the survey were the cardiac ICU intensivists who are part of the network, not necessarily cardiac ICU directors, but many people who have expertise in this area and know what's going on in their units. And what we found was the most common family engagement practices were allowing family members to visit anytime they wanted, which was called open visitation, with few restrictions, and about 95% of units had that. We found that about 85% of units provided information and support to families. We also, structured care conferences was quite common with 82%. And interestingly, that family participation in rounds sometimes or all the time was 77% of time. So 3/4 of units included family members in their daily bedside rounds, which were higher numbers than we found in that have been reported in the past in kind of general critical care units. We developed something called this median engagement practice score, where we assigned a score to any unit that for any of these family engagement practices or policies. And the maximum score was 9 because there was nine engagement practices, and we found the median score is 5. And most units had between 3 and 7 family engagement practices. One of them had only 1 engagement practice, and one of them had 9. So there's a large variation in how these family engagement practices are implemented. We also just looked at whether there was a difference in engagement practice by region or cardiac ICU type. As you mentioned, there was different types of ICU, cardiac ICUs, such as community or rural or urban. We didn't find any kind of geographic or type variation. And we also looked at strategies that were used by the cardiac ICUs themselves to promote family engagement. And we found that kind of the most successful strategies that were being used in the cardiac ICUs were family presence during rounds at about 41% of the time, communication 28% of the time, and family meeting, family meetings 28% of the time. These were felt to be the things that improved family engagement the most by the clinicians. And we did notice that there were some barriers that were shared between different cardiac ICUs, the most common being COVID-related visitation policies in 38%. And the survey was done kind of at the end of the period, so the COVID lockdown period. So many of these sites had opened up but had experienced visitation restriction during that time, which many clinicians felt was an extreme barrier to family engagement. As well as resource limitations in about 13% of units, which means that they didn't have the kind of resources necessary to implement the types of family engagement practices and policies that they wish they could.
Well, that's incredibly insightful, and I think really sort of lays the foundation for what the current state of family engagement practices are. I wonder, sort of, in a lot of what you said really kind of resonates. I think it rings true with my own practice environment as a critical care cardiologist. I wonder if you might sort of comment on, what should we do with this information? And are there clear areas for improvement in family engagement in the cardiac ICU environment? Obviously, some of these were era specific, some of the COVID-related findings, but a lot of those themes will kind of continue to be true going forward. Where do we go from here?
Yeah, so a good point in terms of the COVID. One of the areas we can engage family members even when there is visitation restriction, which we never know could happen again in the future, would be to ensure that we have ways of engaging with family members virtually. So involve them potentially virtually in cardiac ICU rounds, having more communication sessions with them on a virtual basis so that they can be engaged in care. And there's some evidence that we can do that. Which goes to my larger point, which is, as leaders in the field, we need to look at our institutions right now and see what our current practices are and how we can increase family engagement practices and policies. Many times there are clinicians that want to be involved in engaging families more, but don't know how, or they have policies at their institutions that make it challenging to do so. So it does take a kind of a cultural change, and it can start with the leadership to implement practices that have become they're evidence-based. And on that point, we really need more evidence. So there is emerging evidence that, as I mentioned before, that engaging families in care can help, and there's a number of practices which have been shown to help with randomized evidence. But we really need to move the evidence needle forward in order to help sway clinicians, change guidelines, and change practice. And the final point I have is we really need to collaborate on innovative approaches to increase family engagement and care. We have digital technologies. We need artificial intelligence. We need ways to engage families in care while keeping in mind that it does take time and resources, which are not always so abundant in our current system. So there's a need to do it in a way that is time efficient, but we can also improve our communication with family members and improve outcomes for patients ultimately.
Well, challenge accepted. I think you outlined nicely what our goals are. Wearing your leadership hats and your investigative hats, I think that this is really an important first step in understanding where we are right now and where we need to go. Thank you so much for sharing your work with us, and thanks for joining us today.